personality disorders, and cluster B personality disorders, and borderline personality disorder in detail. What is personality? Personality is a unique and relatively enduring internal and external aspects of a person's character that influence behavior in different ways. WHO definition includes the ingrained patterns of thought, feelings and behavior that are characterized by an individual's lifestyle and mode of behavior resulting from the constitutional factors, development and social experience. What is personality disorder? Personality disorders are maladaptive and inflexible patterns of behavior deviating from their expectations, manifesting in cognition, affectivity, interpersonal function and impulse control. The concept of personality. First, Sigmund Freud defined instincts as basic elements of personality, and he described the structure of personality which consists of ego and superego, and explained the psychosexual stages of development. Followed by which Carl Jung explained the personality as attitudes, and he described as introversion and extroversion. And Erik Erikson demonstrated the psychosocial stages of development, followed by which Alport described the nature of personality and how the personality traits are evolved. And Hans Eysenck described the approach to personality, and he gave the 5-factor model of personality. Evolution of personality disorders in the DSM-5. In DSM-1, the personality pattern disturbance which is inadequate and paranoid and cyclothymia and schizoid are included in one category, whereas personality trait disturbance which includes emotionally unstable, passive aggressive, dependent and aggressive type are included in one category, and compulsive type is mentioned separately, and sociopathic personality disturbance is mentioned as another category which includes antisocial and dissocial personalities. Where from DSM-1 to DSM-2, the personality pattern disturbance inadequate is continued as is and paranoid is continued as is, whereas cyclothymia is and schizoid are continued, and emotionally unstable trait is converted to hysterical, and dependent and aggressive dependent type is added as obsessive compulsive, and passive aggressive aggressive type is continued as passive aggressive, and sociopathic personality disturbance is continued as antisocial and explosive personality. But whereas in DSM-3, the cyclothymia is added as cyclothymic disorder axis 1, and cluster A is formed from paranoid and schizoid and schizotypal, whereas cluster B is formed from hysterical, which is now called as histrionic, and antisocial from sociopathic personality, and borderline and narcissistic from the passive aggressive and impulsive traits. And cluster C is formed from the obsessive compulsive, which is in DSM-2 to compulsive type, and avoidant and dependent and passive aggressive types. And the intermediate and the explosive type is again described in the axis 1 as intermittent explosive disorder. From DSM-3 to DSM-4 and 5, the paranoid is continued as it is and schizoid is continued as it is, schizotypal, whereas in cluster B, narcissistic, borderline, antisocial and histrionic are included, and cluster C, compulsive is changed to obsessive and compulsive type, and avoidant and dependent are included. Difference between DSM-5 and ICD-10 includes in cluster A only paranoid and schizoid are included, whereas in DSM-5 schizotypal is included as personality disorder, and under cluster B dissocial personality, whereas the same thing is mentioned as antisocial personality in the DSM-5, and borderline in DSM-5 is mentioned as emotionally unstable, which includes two types, impulsive and borderline subtypes, and histrionic is same in ICD-10 and DSM-5, whereas narcissistic personality is present only in DSM-5 and ICD-10 anantastic, the obsessive compulsive personality in DSM-5 is mentioned as anantastic in ICD-10, and the anxious, avoidant and dependent are the same in ICD-10 and DSM-5. The personality disorders. The personality disorders are broadly classified as cluster A, B, C, and other personality disorders like personality change due to another medical condition, and other specified personality disorders and unspecified personality disorders. Cluster A includes, as I mentioned earlier, paranoid, schizoid and schizotypal, and cluster B includes antisocial, narcissistic, histrionic and borderline, and cluster C includes avoidant, dependent and obsessive compulsive. Today we are going to talk in detail about the cluster B personality. What is cluster B personality? A personality cluster characterized by self-centered concerns, dramatic gestures, changeable mood, anger, frustration, a tendency to blame others for personal misfortunes, and unpredictable behavior and thinking. They have a genetic relationship with mood disorders, that is depression and bipolar disorder, as well as substance abuse disorders. We are going to talk in detail about the antisocial personality, histrionic, borderline and narcissistic. First comes the antisocial personality disorder. Antisocial personality disorder is characterized by a pattern of disregard for the safety and the rights of others without feeling remorse. The individuals with this disorder are unreliable, manipulative and incapable of lasting relationships and are unable to conform to the social norms. The disorder starts early in the age, before the age of 15 years. The prevalence rate of about 3% is consistently found in the general population and more frequent among males compared to the females, and the sex ratio ranges from 2:1 to 7:1 and more common among people from the urban background and low socioeconomic groups. The DSM-5 diagnostic criteria includes the score as 301.7. At least 3 out of the 7 following should be present in a pervasive pattern. Failure to conform to the social norms and with respect to the lawful behaviors as indicated by repeatedly performing acts that are ground for arrest, and deceitfulness and impulsivity or failure to plan ahead, irritability and aggressiveness, reckless disregard for safety of self or others, consistent irresponsibility as indicated by repeated failure to sustain consistent work behavior, lack of remorse as indicated by or being indifferent or rationalizing behaving got mistreated or stolen from others. And the individual is at least the age of 18 years and there is an evidence of conduct disorder with the onset of before the age of 15 years, and the occurrence of antisocial behavior is not exclusively during the course of schizophrenia or bipolar disorder. The ICD-10 criteria include the personal callous unconcern for the feelings of others, gross and persistent attitude of irresponsibility and disregard for the social norms, incapacity to maintain enduring relationships, and very low tolerance to frustration and low threshold for discharge of aggression including violence, and incapacity to experience guilt and to profit from experience, marked proneness to blame others, etc. And there may also be persistent irritability as an associated feature, and conduct disorder during the childhood and adolescence through not invariably present, but whereas in DSM-5 criteria, conduct disorder must be present at the age of 15 years. Comorbidities and cause. Antisocial behavior is mostly pronounced in early adult years and gradually decreases with the age. Maturation of the personality might also take with depression or hypochondriasis emerging with rage and aggression when rage and aggression are apparent. And these patients are at increased risk of impulsive control disorders, major depression, substance abuse or dependence, and pathological gambling. Substance abuse is risky behavior for developing HIV infection, more common in antisocial personality. Management. The efficacy of psychotherapy is very little in antisocial patients. Fear of intimacy causes difficulties in establishing a therapeutic alliance in such patients, and therapeutic communities based on the principles outlined by Maxwell Jones with a general social adjustment as the main task and gave the positive results previously. Pharmacotherapy for anxiety and depression and somatic complaints, SSRIs can be used, and for aggressive behavior, anticonvulsants like carbamazepine and valproate can be used, and for if ADHD is present, psychostimulants like methylphenidate can also be used. Benzodiazepines are contraindicated since they might cause behavioral disintegration. Next comes the narcissistic personality disorder. Narcissistic personality disorder is characterized by exaggerated sense of self-importance with lack of sustained positive regard for others, grandiosity in fantasy or behavior, and constant craving for admiration and external gratification are the additional features of this disorder. Prevalence ranges from less than 1% in the general population and most frequently diagnosed among males. DSM-5 diagnostic criteria is scored as 301.81. A pervasive pattern of grandiosity and need for admiration and lack of empathy. At least 5 of the 9 should be present, which includes has a grandiose sense of self-importance and is preoccupied with fantasies of unlimited success, power and beauty, and believes that he or she is special and unique and can be only understood by or should be associated with a special or high status people, requires excessive admiration, has a sense of entitlement, and is interpersonally explosive, takes advantage, explorative, takes advantage of others to achieve his or her own needs and ends, lack of empathy, and is often envious of others and believes that they are envious of him or her, and shows arrogant behaviors or attitudes. The comorbidities that can be associated with narcissistic personality disorder are major depression, dysthymia, and substance abuse, anorexia nervosa. They may display some features of bipolar disorder, and however the mood swings are of limited duration and change rapidly while insight is maintained here, and hypochondriasis and anxiety disorders are also the frequent complications. It is the narcissistic personality has a chronic course, and the aging is handled poorly by these patients, and patients value beauty and strength and youthful attributes to which they cling inappropriately. Management, anxiolytics and antidepressants may be helpful in alleviating the episodes of mood and anxiety symptoms. Lithium can be used for mood swings. Individual psychotherapy is aimed for analyzing the idealizing transference and interpretation of the self-grandiosity. First stages, only supportive therapy is considered until integrated attachments are formed, and some clinicians advocate group therapy for their patients so that they can learn how to share with others, and under ideal circumstances they can develop an empathetic response to the others. Next comes the histrionic personality disorder. It is characterized by excessive emotionality and attention seeking, and by dramatic, colorful and extroverted behavior. They are egocentric, dependent and demanding interpersonal relationships are typical of this disorder, which begins in the early adulthood, and it was introduced by Kraepelin. The Diagnostic Criteria for histrionic personality disorder, it was scored as 301.50. A pervasive pattern of excessive emotionality and attention-seeking behavior. At least 5 of the following 8 should be present, which includes is uncomfortable in situations in which he or she is not the center of attention, and interaction with others is often characterized by inappropriate, sexually seductive or provocative behavior, displays rapidly shifting and shallow expression of emotions, consistently uses physical appearance to draw attention to self, has a style of speech that is excessively impressionistic and lacking in detail, and shows self-dramatization, and is easily suggestible, easily influenced by others or circumstances, and considers relationships to be more intimate than they actually are. The ICD-10 diagnostic criteria includes at least 3 of the following should be present, which include self-dramatization of theoretically exaggerated expression of emotions, suggestibility, easily influenced by other circumstances, shallow and labile affectivity, continually seeking out for excitement, appreciation by the others, inappropriate selectiveness, in appearance or behavior, over concern with the physical attractiveness. Management. Depressive and anxious symptoms are more frequent in histrionic personality disorder, which can be treated with antidepressants. Psychoanalytic techniques in histrionic patients are oriented to clarification of the patient's covert inner feelings, and they also taught more appropriate and acceptable ways to negotiate in order to get their demands fulfilled. And clear limits should be set, and demanding dependent behavior should not be rewarded. Borderline personality disorder. Introduction. Borderline personality disorder is characterized by intense affective instability and impulsivity, together with an unstable sense of self-identity. It is often manifested by impulsive self-aggression and suicide attempts, substance use and abuse, chronic feelings of emptiness, and persistent pattern of severely unstable interpersonal relationships. It is also known as emotionally unstable personality disorder or emotionally intense disorder. History. The term borderline was first used by Stern in 1938 to demonstrate a group of syndromes placed in between neurosis and psychosis. But the characteristics that now define borderline personality were described by Gunderson and Knopp, and Kenberg developed the term borderline personality organization, which is based on the 3 criteria, which includes diffuse identity and the diffuse mechanisms like splitting, denial and projection, and intact reality testing. There is no definitive prevalence studies available on borderline personality disorders, but prevalence ranges from 1.5 to 5% in the general population, and the disorder is most commonly frequent among females compared to men, and they are initiated between the age groups of 18 to 35 years. Etiology is biology is divided into 3 components: biological, psychological and social. No single factor explains the development of borderline personality. Multiple factors play a role. The biological factors include the temperamental characteristics, that is the pattern of thought characterized an individual and are stable over time. And the family history studies have found that impulsive behavior disorders such as antisocial personality disorder and substance abuse are particularly common among first-degree relatives of borderline personality disorder. And studies of central neurotransmitter activity shows associated with reduced serotonin levels in the cerebrospinal fluid, and hypothalamic pituitary adrenal axis dysfunction is commonly seen, and increased sensitivity in the amygdala and insufficient regulatory function in the cingulate and anterior prefrontal cortex is commonly seen. The psychological factors include higher incidence of childhood traumatic experiences, both sexual and physical abuse or neglect, that has been demonstrated in these patients. Most of them report self-abuse from the caretaker. And adverse life events can produce sequelae in the vulnerable population. And developmental factors include deficiencies in self and identity development linked to the attachment failures with the parental figures in the early developmental phases. The social factors include recurrent suicide attempts are less common in traditional societies in which there is a little change from the one generation to the next, but in the current societies undergoing rapid change, it became more common. The onset of borderline personality disorder needs the interaction of predisposing factors, both biological as well as developmental and the environmental perspectives. The DSM-5 criteria include the pervasive pattern of instability or interpersonal relationships, self-image and effects and marked impulsivity beginning in the early adulthood, and 5 of the following 9 should be present, which includes frantic efforts to avoid real or imagined abandonment, and a pattern of unstable interpersonal relationships characterized by alternating between devaluation and idealization, and impulsivity in at least 2 areas that are potentially self-demanding include spending, sex, substance abuse, reckless driving and binge eating, and identity disturbance, marked disturbance in the marked and persistently unstable self-image, and recurrent suicidal behavior, threats or self-mutilating behavior, affective instability due to marked reactivity to the mood, chronic feelings of emptiness, inappropriate, intense anger, feelings of anger and difficulty in controlling anger, and transient stress-related paranoid ideation or severe dissociative symptoms. The ICD-10 criteria includes, it is scored as 60.3, emotionally unstable personality disorder, a personality disorder in which there is marked tendency to act impulsively without considering the consequences together with affective instability. The ability to plan ahead may be minimal, and the outbursts of intense anger may lead to violence or behavioral explosions. It is divided as 60.30, that is impulsive type, and 60.31 borderline. The impulsive type constitutes of emotional instability, lack of impulse control, and outbursts of violence or threatening behavior are most particularly common, which are particularly in response to criticism by others. Whereas borderline type includes often self-image, aims and internal preferences are often unclear or disturbed, and emotional instability, chronic feelings of emptiness, suicidal threats or acts of self-harm, excessive efforts to avoid abandonment, are common. The clinical features includes 4 components: affective symptoms, impulsive symptoms, and interpersonal symptoms, and cognitive symptoms. The affective symptoms include the rapid mood shifts in which emotional states tend to last only for a few hours, and when affective instability is monitored with standardized instruments, emotions are found to be intense but reactive to external circumstances and with strong tendency towards the anger outburst. Levels of affective instability are more predictive of suicide attempts. The cognitive style of borderline patients are easily suggestible and frequently change their decisions, and things and people are seen in black and white terms, and transient and brief psychotic episodes are frequent of borderline personality disorder associated with unstructured stressful situations. Psychotic symptoms may have a typical dissociative-like nature or present as transient self-referential ideation. Interpersonal relationships are unstable, intense, demanding, and impulsivity should be present at least in 2 areas that are potentially self-damaging, as mentioned above. The comorbidities associated with the borderline personality include affective disorders, that is major depression, dysthymia, and double depression, and anxiety disorders, somatization disorder, post-traumatic stress disorder, and alcohol abuse disorders. Differential diagnosis: it is important to differentiate the mood swings in the borderline personality and depression. In depression, the lower mood is extended and it is continuous, whereas the low mood in borderline personality disorders is short-lived and subclinical, and it is intermittent. And the mood swings in borderline personality, there is rapid shift in the mood from depression to anger often lasting only for hours, whereas in borderline, each mood lasts for at least 1 week, and there are extremes of the mood, but they are not intense. And the cognitive dysfunction includes the auditory hallucinations that are intermittent and are related to stress, mostly in borderline personality, whereas hallucinations, mainly auditory, are more continuous and are recognized as hallucinations by the patient in schizophrenia. And there are no delusional trends, and whereas there are fixed delusions in the schizophrenia. And other bipolar 2 disorder, the emotional ability from sadness, apathy to euphoria is present in bipolar 2, whereas in borderline personality disorders, intense and reactive instability shift from sadness to tolerant dysphoria. And in intermittent explosive disorder, there is impulsive and aggressive behaviors, whereas in borderline, apart from impulsive and aggressive behavior, there is additional affective instability. And in mild mental retardation, there is intense irritability, lability, and impulsive and aggressive behavior. But in borderline personality disorder, additional chronic feelings of emptiness and lack of self-identity are more common. There are also other disorders, that is personality change due to other medical conditions and substance abuse disorders, which has to be ruled. Assessment includes a detailed clinical history and psychological assessment. The objective tests used include Minnesota multiphasic personality inventory, 16 personality factor questionnaire, personality assessment inventory, California personality inventory, ISIC personality questionnaire, the big 5 factor by Costa okay, and international personality disorder examination on ICD-10, which is commonly used. Management includes both psychotherapy and pharmacotherapy. Psychotherapy techniques that can be used include Dialectical behavioral therapy, transference focused therapy, and mentalization based psychotherapy, whereas pharmacotherapy is symptom management. Psychotherapy is the treatment of choice for borderline personality disorder. Supportive psychotherapy is suggested for more fragile borderline patients who are prone to serious aggression, combined with the psychoeducation should be given. And therapists use behavioral therapy to control the patient's impulses and anger outbursts and to reduce their sensitivity to criticism by the others. Social skills training, especially with videotape playback, helps to enable patients to see how their actions affect others and thereby improve their interpersonal behavior. And a reality-oriented approach is more effective than in-depth interpretation of the unconscious. Dialectical behavioral therapy, it is based on cognitive techniques associated with reality confrontation. The major aim of is emotional self-regulation and behavioral self-control. It is indicated for control of suicidal and impulsive behaviors and treatment of emotional reactivity. The techniques include group skills training, individual therapy, or consultation. A consultation team is formed, and the group therapy usually skills training on a weekly basis is done in the group session. This includes mindfulness training and teaching of new coping skills. And the individual therapy is lasts for 60 minutes once per week, and the components used in the therapy includes mindfulness, distress tolerance, emotional regulation, and interpersonal effectiveness. Mentalization based psychotherapy. Mentalization is a social construct that allows a person to be attentive to the mental states of oneself and of others. It comes from a person's awareness of mental process and the subjective states that arise from the interpersonal interactions. Mentalization based psychotherapy is based on a theory that borderline personality symptoms such as difficulty in regulating emotions and managing impulsivity are a result of patients' reduced capacity to mentalize. Thus, it is believed that recovery of mentalization helps patients build relationship skills as they learn to better regulate their thoughts and feelings. Transference focused psychotherapy. It is modified form of psychodynamic psychotherapy based on Kernberg's object relations theory. The therapist relies on two major processes in working with the patient, that is clarification and confrontation. Clarification is transference is analyzed more directly so that the patient becomes quickly aware of his or her own distortions about the therapist. And the confrontation is the therapist points out how these transferential distortions interfere with the interpersonal relations towards others. If the therapy is successful, then the need for splitting diminishes and the object relations are improved and a more normal level of functioning is achieved. Pharmacotherapy includes newer antidepressants including SSRIs and venlafaxine has shown positive effects in treating the broad spectrum of acute symptoms including the depression, hostility, irritability, anxiety, and suicidal attempts and impulsivity. Antipsychotics and anticonvulsants can be used for aggression and anger outbursts. Prognosis. Borderline patients often experience profound dysfunction in many important aspects of life including education, jobs, partners, partner relationships and marriage. Fortunately, most patients with borderline personality disorder improve with time. About 75% will regain closer to normal functioning by the age of 35 to 40 years, and only 90% will recover by the age of 50. About 1 in 10 patients eventually succeed in committing suicide, and impulsivity generally decreases with the age, and patients learn over time how to avoid situations that give them the most trouble. The references include the Oxford Textbook of Psychiatry, ICD 10 and 2005, Kaplan and Sarah Comprehensive Textbook of Psychiatry, and the article of Borderline by Joel Carlos. Thank you.